Hello, everyone. My name is Elisa Grishman. I am a fat white woman with curly brown hair, wearing a purple shirt, and with paintings on the wall behind me. We want to welcome you tonight to Access Mob Pittsburgh's community lecture night. A little bit of housekeeping before we begin. Uh, Closed captions are available, and there's a link to the transcript that's going to be going in the chat now. We do ask that uh, you please remain muted and keep your cameras off unless you are one of the official speakers. Um, if you have any sort of problems, you may message in the group chat the Access Mob Pittsburgh facilitator. We keep the chat off otherwise during the main section just for access needs for people who need the screen readers and stuff. But yeah, you can message Access Mob Pittsburgh facilitator. Um, if there's time for a Q&A at the end, you can please raise your hand. You can either use the virtual reaction on Zoom, or if you are calling in on your phone, it is *9 to raise your hand and *6 to unmute yourself. And when you are called on, you will be asked to unmute and or turn on your camera. You may ask your question verbally or in ASL, or if you don't want to do either, you can type your questions in the chat and our facilitator will read them out loud. You do not have to turn on your camera unless you need to ask or uh, unless you need to ask in speak in ASL. I'm sorry, pardon me. If we don't have time to get to everyone's questions, you can email them to accessmobpittsburgh@gmail.com. That's accessmobpittsburgh@gmail.com, and we can get your questions to the presenter. That's also for people watching this later on YouTube. If you have any questions, please feel free to ask them at that email address. And yeah, we will do our best to get in touch with the meeting facilitator. Sorry, a cat just jumped up next to me and thoroughly distracted me. I'm okay, but we'll be able to get the question to the presenter and try to get it answered for you. Um, Before we begin, I would very much like to thank my board of directors, Debbie, Donna, Kendra, Monica, and Nyota. You people are terrific, and I think the world of you. Special thanks to Katie for being our meeting facilitator. She's in charge of all the technical aspects of what's going on. Uh, Special thanks to Disability Pride Pennsylvania. They are our fiscal agent for Access Mob Pittsburgh, helping us have 501c3 nonprofit status. And a huge, huge thank you to the Three Rivers Community Foundation, whose grant is providing all of the funding for today's lecture. For anyone who's attending in person right now, at the end of this lecture, or later tonight, I will be sending out a survey. We would really appreciate it if you could fill it out just to let us know what went well, what we could have done better, if you had any access needs that weren't met. Please just take a few minutes to fill it out, and yeah, we will be able to help you. Uh, that's it for the housekeeping. So I'm going to move on in the slides if this will let me. There we go. Tonight's lecture is Ableism in Medicine. It's representation, the solution we need. And our speaker is Monica Albert Still, RN, BSN, who's a nurse clinical care coordinator in at the Physical Medicine and Rehabilitation Department, Adult Spina Bifida Clinic at the UPMC Mercy Pavilion. And she has provided her email address for direct communication. It's still M2, so STILL M as for Monica and the number 2 at upmc.edu. Monica Albert Still, RN BSN, is an adult with spina bifida who is proud to be among the first generation of kids with spina bifida on the threshold of senior citizenship. She lives in the wilds of western Pennsylvania with her tribe of cats. Monica is the mom to two beautiful adult daughters and grandmother to one adorable girl. She is very proud of the women that they are growing into. Monica spent most of her life in Connecticut and graduated magna cum laude from Southern Connecticut University with her bachelor's degree in nursing. She has spent her nursing career keeping people in the community, working her way from client care in the home to starting two home health care agencies. As the administrator, she decided to take on a new challenge. After 30 years in nursing, she has now turned her focus to the advocacy part of nursing and serving her community on a broader level. She's involved in advocacy at the local, state, and national levels. Monica currently serves as a board member of Access Mount Pittsburgh. She's honored to serve as the secretary of the board for Disability Rights PA, chair for the Mental Health Advisory Council, and member of the Connecticut Health Law Project Board. She's on the planning committee for Disability Pride Pittsburgh. She is also a founding member of the Spinal Bifida Association Adult Advisory Council and continues to serve to this day as well as serving on various other committees. She returned to nursing when she got her dream job at the UPMC Adult Spina Bifida Clinic. She combines care with advocacy. So without further ado, I'm going to turn this over to Monica.
Thank you so much, Elisa. And if we can forward it, let me describe myself. As Elisa said, I'm Monica Albert Still. Most people just call me Mon. My pronouns are she and her. And I am also a fat white woman um, that is almost a senior citizen. I have purple hair on top with a little bit of blue streaks on the bottom. And I am wearing a top that is paisley with multiple colors, but mostly it's blue. So, with no further ado, let's get started. If we can move to the next slide, please. Yeah, you can tell I do study stuff. I have no conflicts of interest to report. And next slide, please. There are just some objectives that I wanted to show to people of what I hope you get out of this lecture. If you have any questions or want to bring up anything or have a discussion in the future, I am more than happy to speak with people, and I am in the Pittsburgh area. So, next slide, please. Let me tell you a little bit about me and a little bit about my journey, because my journey ties into how I learned about ableism in medicine and on both sides of the bed, as it were. I spent a good part of my childhood in the hospital. Being born with spina bifida means comes with a lot of surgeries. So I spent a lot of time at Yale New Haven Hospital, which is very similar to Children's here. Um, Teaching hospital is teaching hospital. And I got used to being around nurses. I got used to being around medical people and kids who were like me with different problems, and some with chronic illness, some with disabilities, and some with illnesses that would eventually be cured. But it gave me a sense of who was around me and to listen to other people and to realize that there are just so many different ways of being a human in this world. I come from a family of nurses. I swear to you, there must be a nursing gene because I didn't even realize that some of my family were nurses, and yet I had always wanted to be a nurse. When we were out playing, there were like a bunch of boys in my neighborhood, and they would like to play Army. Well, I would always be the nurse. And it wasn't so much a gender role as it was my choice, what I wanted to do. Of course, I was also a nurse that would be a spy, but when you're 9, you do whatever. Um, I started school like other kids, but unlike other kids, my mother had to go before the school board because I was born before the time of that they had to educate disabled children. And so my mom went before the school board with my nursery school teacher and with my pediatrician to let them know that I should be educated. And throughout my journey in school, it was always a fight to keep me in, to gym class was awful. I obviously couldn't do what the other kids did, but I didn't want to be graded or downgraded, or I was a nerd who liked to get straight A's. So I didn't want to get downgraded because I couldn't do something that frustrated me to no end. So it went to throughout my school years, one day at a time, taking one fight at a time, till finally I went to high school, and it got to be my senior year. And of course, everybody knows I have spina bifida. At the time, I was able to walk without assistive devices, but I didn't walk well. And I did have, I had kind of the spina bifida toddle, or what we like to call the Biff swagger. And people held that against me and thought I couldn't do things because of it. So I had in school, I had oh my goodness, my mind, I'm sorry. In school, I was told that I would never be a nurse. And I will admit, even though I really wanted to be a nurse, that was the push that gave me to do it when the guidance counselor told me that. So I applied to colleges like anybody else does. I got accepted, but I didn't get accepted into their nursing programs. So I had to fight my way into nursing programs. Again, pre ADA. Yes, they got federal funds, so it would have fallen under 504, but it still was a fight because this was during a time when 504 was applied sporadically, despite the great work of Judy Heumann and the people of Crip Camp. So I did become a nurse. And my career goal was always to be a pediatric spina bifida clinic nurse. Well, at the time I said pediatrics because there were no adult clinics for adults with spina bifida, despite the fact that I was an adult with spina bifida. And I was told that I was too close to the subject matter, that my lived experience didn't count for anything. As a matter of fact, my lived experience made it more difficult for me to, how they put it, distance myself from patients. It's not the kind of nurse I wanted to be. So I went on to do home care and did very well at it. Um, you know, I can honestly say that I am amazed in the change. I said 30 years as a nurse. I realize I'm coming up on 40, which, wow, time flies. Um, the change in 40 years, especially in the last, I want to say about 4 years or so, that people are looking at lived experience, not just in healthcare and giving care, but in research and looking and asking the communities, what do you want? What do you need? That change is was needed. And I don't think we've done enough on the side of having caregivers who are disabled or who are chronically ill. So that's a little bit about what I want to talk about tonight. And I can honestly say I am extremely thankful to every day to serve the community that I'm a part of. And that's whether it's the spina bifida community or the broader disability community. Because I think the way we are going to move forward is by working together and working with each other. Next slide, please. Let's look at the state of the disability community in 2023. This is the last data that I had for this. This was released in February 2024. The employment rate for people with disabilities was 7.2% in 2023. That's twice that of people without disabilities. The reported unemployment rate for people with spina bifida is at about 20%. So imagine that 20% of a community are not employed. 20% of a community don't have access to health insurance like everybody else does. People with a disability are much most likely to work in management positions. A lot of that has to do with how much salary you make and whether or not you lose your benefits. A lot of that has to do with OVR, who talks about doing things like they'll make sure that you get your bachelor's degree, or there's this kind of mindset with different subgroups in the disability community that all they can do is this kind of job and not have job growth, which is wrong. People with a disability are less likely to have completed a bachelor's degree or higher than those with no disability. Among both groups, those who have attained higher levels of education were more likely to be unemployed than those with less education. I mean, we know this. You're more likely to employed the more education you gain. Next slide, please. Ableism in healthcare. According to the December 18th, 2023 issue of the Lancet, and I'm going to read this exactly so I don't get it wrong. Structural ableism is a system of historical and contemporary policies, institutions, and societal norms and practices that devalue and disadvantage people who are disabled, neurodivergent, chronically ill, I hate this term and forgive me, mad, and or living with mental illness, and privilege people who are positioned as able-bodied and able-minded. Again, please forgive the term mad. This is what they said. I think mental illness, personally, I think mental illness covers it. But this is not something we don't know. We know that there are policies and institutions that harm us, that there is ableism rampant in medicine. I don't need to go over example after example after example because y'all have lived it. And that is something that is very concerning to me. I have been, like I said, on both sides of the bedside, and I can tell you that I have heard things that have been said in front of me because I'm a nurse and because I kind of flew under the radar with disability. They forgot that I was disabled too. And some of the things that were said, granted this was years ago, angered me and disgusted me. Next slide, please. The National Council on Disability found that much of the federal research effort remains focused on disability and disease prevention rather than improving access and quality of healthcare for people with disabilities, reducing their incidence of secondary health problems, and promoting healthy living. And this was from an article in June 27th, 2023. And this is a problem. I am not anti, prevention, obviously. But the thing is, we also need to remember that there are people here living with whatever disease, whatever disability, whatever chronic illness that you may have. And we need to do better by these people. We need to do better for our community. because it's great if we prevent something like we prevented polio, resurging possibly, but we prevented polio. That's great. Awesome. But what about the people who had already gotten it? Why aren't we looking at what their needs are and how to improve their quality of life? Not just having them survive, but having them thrive and become active members in our society. And a lot of that happens through medicine. Next slide, please. This is a quote that I loved. And getting the healthcare piece right for people with disabilities is the gateway for progress in other areas like employment. And that was from Neil Romano, National Center on Disabilities, and again, June of 2023. I agree with this, but I would twist it a little bit. I think that improving employment for people with disabilities improves their health care. And it goes both ways. That if you have better health care and you have the experience of getting what you need, then you are able to get a job, which is great. But if you have a job, if you have sometimes commercial health insurance can be, not always, better than sometimes what Medicare or Medicaid do. Like I said, not always. Um, that has changed a lot over the years. Actually, currently, I think they just don't want to pay for anything. But, there are things that you can access when you're employed other than insurance. Hopefully, you have disposable income. That if there's something that isn't paid for or something that isn't considered medically necessary, that you can get it. One example that I can give is for myself. I have a wound on my leg, and basically it is not healing yet again. And the doctor suggested this new dressing that my insurance has never heard of. They don't want to pay for it. It was developed by this doctor, and I can get it off of Amazon. Well, that's great. If I didn't have the disposable income to get that, I wouldn't be able to try it. A lot of having a disposable income, and sometimes I will admit, it galls me that I'm spending it on things that make me able to live like everybody else because insurance companies or the government or whoever doesn't find that necessary, that you can survive, but you can't thrive. Next slide, please. The current climate of healthcare and disability, this is just, this angers me beyond belief. We have all heard of this study. It is the um, Health Policy Research Center at Massachusetts General of about 700 practicing physicians, and the numbers are appalling. 82% reported people with significant disabilities have a worse quality of life than non-disabled people. We saw that. We saw that during the pandemic. How many disabled people died or were taken away ventilators from, despite families begging, despite people saying, no, he has a good quality of life, because they were operating on bias. 40% of physicians were confident about their ability to provide the same care, quality of care to patients with disability. That's interesting. I think they need to really reflect on that because I don't think that number is accurate. 56, almost 60% strongly agreed that they welcomed patients with disabilities into their practices. Now let's think about this. Let's say 57% welcomed people. So that means that 43% don't want to see us? That's outrageous. Imagine if they said that about any other marginalized group, the outrage that people would have. And then 18% strongly agreed that the healthcare system often treats these patients unfairly. And again, look at that number, 18%. They don't get what they're doing. We need to remind, they don't understand that they are discriminating against us. So, what do we do? What can we do to change this dynamic? Next slide, please. It started within NIH calling for change, and they decided to listen to the National Council on Disability and put it together that the disability community is in need of studies and research based on health disparities that they experience. Research needs to be done. We are a minority group, the biggest minority group, and the country needs to research what we need and needs to address it. We need to do that now. They started in 2023. I am not going to get political, other than I can honestly tell you I don't know what's going to happen in the immediate future. Next slide, please. Systemic goals. We need to have some goals, and we need to start in medical schools, nursing schools, any allied health, looking at the language we use in practice and the attitudes that we have towards people who are disabled. This is what they need to do. This is what the medical profession needs to do, healthcare in general. Look at this and break down these barriers. Part of the problem, and I never realized this, was that some medical schools still have a requirement that you have a physical and that you be physically fit, whatever they use by that definition, to go to medical school. Nursing schools still do this nonsense. Allied health schools do this. There are jobs in each of those areas that people can do and can do well with the right accommodations. And it irks me to no end that we're still at this place. And I graduated from college in 1987. This is interesting. According to a paper published in the Canadian Medical Educational Journal in 2022, adults with disabilities are 3 times more likely to report unmet health care needs when compared to the general population in Canada. So it's not just a US problem. It is not just our healthcare system is set up the way it is for profit problem. They have these problems in Canada. They have these problems in England. They have these problems in other countries as well. Next slide, please. And combating ableism in healthcare, again, talking about that. There is also a 2019 study found that 4.6, less than 5% of medical students identified as having a disability. And they also related that saying that they had a disability was dependent upon the openness of the medical institution. And I can honestly say it's dependent upon the professor, it's dependent upon the people you're around. This is outrageous. We should have more people with chronic illnesses. And yes, medical school is hard, but again, supports and accommodations can help with this. And then a study in 2021 identified the prevalence of providers with disabilities as, this is even worse, 3%. 3% of people who are providers of healthcare, whether they be a nurse like me or they are doctors. It's getting better. For the longest time, I was the only nurse I knew of that had spina bifida. There are younger nurses with spina bifida, which is awesome, but we need to do more. And when you think about this number, 3%, compared to the number of people who are disabled in the United States at this time was almost 27%, and I'm sure that's going up. So 3% of 27% just work in healthcare. That's part of the problem. They don't see it. I can honestly say that when I'm working in different situations I've been in, I have not been seen as a colleague. This was especially true when I first started out in nursing. Not so much that I was working um, way back when in the 80s, as it was that I had nurses who had taken care of me and a doctor who had taken care of me who kept introducing me to patients as one of their kids, one of the kids they took care of, perpetually a child. Very difficult to establish your career when, as a 20-year-old, I looked like I was 12 anyway, and having people introduce you as one of their kids. Next slide, please. There is some good news, though. In 2019, Lisa Meeks and I'm going to butcher her name, Swenner, wrote the first. Okay, now I want you to think about this. This is 2019 that they wrote the first book that was for medical schools to do a curriculum about disability. Moving beyond mission statements called for the inclusion of disabled clinicians to help alleviate the persistent ableism in healthcare system. 2019, had doctors forever. The disability rights movement started 60s and 70s. It took until 2019 for somebody to say, hey, we should be in medicine, and to publish about it. Next slide, please. There is a book that they wrote. It is outstanding. I certainly hope every medical school uses it. It's Disability as Diversity, a guidebook for inclusion in medicine, nursing, and the healthcare professions. I just put this out here because I know that you're not all clinicians, but I put this out here because, you know what? You know any clinicians? We all go to doctors. We all see nurses. Talk to them. Tell them that this book exists. First book ever written on this topic. Again, 2020. Next slide, please. And yeah, this is this really long quote that I'm not going to read, but it is, I can provide the slides to anyone because this is such an on point quote of how things have changed, that we have gotten the laws in place in certain areas between 504, the Rehabilitation Act, the ADA, the Airline Carriers Act, but we really haven't changed the hearts and minds of people. And specifically, the system that we rely most on to live, the healthcare system, we have not really even begun to touch that, to make sure that we get the care that we deserve. I love, disability is diversity. We are the group that anyone can join at any time. We do not discriminate. And the future's now. It's past time that we do something about this. Next slide, please. There is, like I said, lived experience information available. There are groups like peer groups that help with mental health. That's where it started. I think actually it started with people who are living with AIDS, and that there's peers that help you navigate the system, help you live your life, like a mentorship program. There are lived experience being utilized in mental health care and also in kind of like a mentorship program. There's also lived experience now being looked at in research. And not just there's there is research being done that research boards are asking us, our community, what do you think is important? What do you need? Because how many times have you seen research about whatever your disability is, and your first thought is, nobody asked for this. Why did you do this? And that they didn't focus on what you thought was important, what you know your community thinks is important. The other part of it is also that they have it as an advisory capacity. The Spina Bifida Association, I talk about it a lot because that's who I'm most associated with about this, has advisory boards for research groups. And every advisory board for different research groups has an adult and also a parent on it of a child with spina bifida, so to make sure that we look at not just children, but also adults. If any of you out there have cerebral palsy, have cystic fibrosis, have muscular dystrophy, have absolutely anything that you were born with, you know that a lot of money, a lot of time, a lot of effort is spent on children. Autism is included in this. Uh, but, and we should. But then when you turn 18, it's like you're magically cured or something that, oh, we're not going to do anything more for you. No, we need to change that. The University of Maryland has a Patients as Professionals program for their pharmacy program. So it talks about, it has people with lived experience talking with their doctoral candidates in pharmacy and how to work with different groups and to get into different groups to be more diverse and not just with disability, but also with communities and to giving back to communities so that they trust you enough so they can do the research. Um, the unit NIH is also using disabled people to evaluate their grant proposals. So we have a voice now, a seat at the table about where the money's being spent. That's important. That's something that I think we all need to be involved in. And the only problem with all of this is that I did a research. Granted, it was just, it did a look at the research available. Went through PubMed, if any of you know what that is, and went through it. And I could not find any research on lived experience professionals to improved patient outcomes or experiences. I'm hoping to do that. Next slide, please. Having professionals and paraprofessionals with disabilities with lived experience as a part of the care team for patients. Think that's a solution? I do. Next slide, please. These are all hypotheses of the benefits, but this is at least what I think and what others on my team think, and hopefully we can prove that they're true. Professional and paraprofessional staff members can serve as role models to both patients and their families. Patients are more likely to discuss issues, especially disagreeing with the team's plan or not following the team's plan with a person who has life experience. I cannot tell you how many times that I need to explain why somebody's non-compliant, that there's a darn good reason for it, and we should not look disparaging at that as healthcare professionals. When I'm with healthcare, sorry, I'm wear two hats, so I'm kind of like going back and forth here, and I apologize for that. Professionals with a disability use their life experience to advocate for the patient's goals with the team, and this leads to patient empowerment and better outcomes. The team and the greater healthcare system gets a broader view of what it is to live with a disability, which hopefully improves care, and not only improves care, but kind of whittles away at that bias that our quality of life is not good. Next slide, please. Pittsburgh is leading the way in this. I work for the Adult Spina Bifida Clinic at UPMC Mercy. We're in the Mercy Pavilion. I like to put that because it is an awesome building, and it is the first time ever I ever worked in a hospital building that wasn't from 1825 that was redone 27 times. Um, our clinic is a holistic clinic that uses an interdisciplinary team approach. 4 out of the 9 team members are adults with spina bifida. We have 9 team members. We have a social worker. We have we have a we have a peer navigator. We have a peer navigator program. For some reason, we can't call it a mentorship program. That I'm not sure why. It's some weird, hinky legal thing. But we have a peer navigator who has spina bifida. We have a personal trainer who has spina bifida. We have a research coordinator because we do a lot of research who has spina bifida, and I am the nurse on the team, and I have spina bifida. And we are looking in the future that if there are other professionals that have spina bifida, we want to hire them. We want to have at least half the members, we're almost there, at least half the members to be people with lived experience with spina bifida. We have a patient advisory board. It's called SBCAN. Um, I have no idea what that means. We just tried to come up with something that was clever. Um, and we ask our patients and ask them, what do we do right? I don't mean the thing that UPMC or any of the hospitals send you afterwards. Hey, did we give you, did we bring you something to drink while you were there? The whole kind of rigmarole that doesn't really address what, at least in my opinion, doesn't address what's important when you go to the doctor. So we ask our people, we ask our patients, what are we doing right? What are we doing wrong? What would you like us to do better? What would you like to see? That's how the Peer Navigator program came into existence because we were told that, gee, we would love to speak with other people with spina bifida. Uh, it blows my mind that there are people out there who have spina bifida that have never met another person with spina bifida, let alone a professional with spina bifida. And then we also talked to our patients and found that we were failing with the transition program, that transitioning from PD to adult care, which is, when you are a teenager or you have a teenager or a young adult, you have to learn how to be an adult. Whether it's how to use a credit card or how to budget or even how to grocery shop. Goodness knows my daughters call me with anything and everything. Add to that being disabled and figuring out how you're going to get your care, what kind of doctors you need to go to. When you're going from this system that the doctors are kind of already there, and now you have to go find your own adult doctors. Or say something happens, like, you have a different problem than what your disability is. You develop high blood pressure, and you have to find the right doctor for that, or the right PCP that understands your disability as well as understanding the things that could happen to any adult, or how insurance works, or how, God forbid, the waiver program works. So there's a lot that we put on children and then teenagers and young adults, and parents tend to not start this early enough, in my opinion. They're not teaching kids how to be disabled adults. And that's what you need to do. So we're trying to do that through our transition program. We have lived experience team members meet and teach children and their families. And we also have a separate transition clinic that we're working on. And we're also talking to them about the greater things. Again, I said holistic, that talking about, gee, have you contacted OVR yet? There are different things that you need to do. Next slide, please. Multiple patients, I have said this, my experience, this is just anecdotal evidence. multiple patients around my age. I'm Gen X. I'll put it out there. I'll be 60 this year, who have never met another person with spina bifida before. I can guarantee you there are people who are disabled with different disabilities because of where they work in where they live in Pennsylvania. They have not seen another disabled person. I live in Beaver County. I don't see other disabled people unless I go down to Pittsburgh. A parent of a young adult was talking about being given hope that her daughter will have a life. My God, why didn't somebody do that when she was younger? Talking openly about issues that they want to fix and those that they believe they can live with. You know, one of the hardest things to get through to people in medicine is we work with the medical model. And the medical model is we must fix everything. And you know what? This is where my disabled side comes out. I don't have to fix everything in me. There's stuff I can live with. I don't mean like if I have chest pain, please don't take me to the hospital. I mean like little titchy little things that I deal with that, yeah, I could be perfect, but the quest to being perfect is going to take way too many spoons than me just living with it. Appear more open to teaching about why they need to fix what they don't want to. Okay, there's some things that, quite honestly, we need to work on. We need to fix. One of the biggest things that I see is, and I'm not gonna, is with why I'm trying to be nice, but there's no way I'm a nurse, so please forgive me. Um, Bowel management. All right, I cannot tell you how many times people are just like, yeah, so what? I'm constipated all the time. There are reasons why you want to fix this. Really good medical reasons why you want to fix this. And so I need to talk about my experiences and how, and look, I didn't want to fix it either. I wasn't doing what I was supposed to do either. And so talking about and going back and forth, meeting people where they are, and maybe we can come to some kind of common ground of where we can work together. And then improved advocacy in and out of the healthcare system. I am very open about my advocacy work. Um, we had a wonderful resident who's now chief resident, John Luke, who last year who went to Disability Pride and had every last PMR resident wearing um, disa- uh, disability rights are human rights buttons. Every last one of them had it. Awesome. And that's the kind of thing we need to do. They see me as a colleague. They see patients coming in and talking to me as a nurse. And then they see me more as a nurse and kind of, it's, I hate to say normalized, but this is it. Disability becomes more normalized. It's not this thing that's out there that we need to fix. It's actual humans, people that we know, that how can we make their lives better? We can see that they're living a fairly good life right now, but what can we do to be better? Next slide, please. I do have some challenges with my experience. The professional personal line blurs because of community involvement. I consider a lot of my patients friends. And I was always taught that there is a strict line between professional and non-professional, and I try to balance that. But the fact of the matter is, I am a part of the community. So you are going to see me, and I'm going to just talk to you like we're friends or whatever, because that's the way life works. And maybe more clinicians need to do that. Like they used to talk about the old doc in the olden days where the doctor was part of the community. That's what needs to happen. I think that is important to do and to be a part of a community and to learn about that community. So it might be a challenge because I'm thinking the old way, but I think we can turn that around to make it an advantage. Um, this is wound pictures sent to me via social media. Yeah, I don't get those nasty pictures from from men. I get wound pictures, and quite frankly, I can't tell what's going on from a picture. So I would prefer not to have that part of it. Um, there's a term in medicine that you can't bleed for every patient, which basically means that you can't break down and cry every time a patient is going through something difficult. That is more difficult for me to do, and I admit that when it is a disabled person or a member of my community. But I am learning to deal with that. Frustrations with learned disability. I cannot tell you how many times I just want to look at keep in mind that I'm dealing with people with disabilities that they're born with, that look at a parent and say, my goodness, why didn't you teach them this? You should have. Why don't you have a plan for the future? And that is very frustrating. Um, and again, that kind of flows into concern for patients who have no future plan if their primary caregiver dies. Or, quite frankly, right now, I am very concerned about patients who don't have direct care workers or what's going to happen to the direct care workers. Um, Anger, frustration with the system. You can tell I am very much um, frustrated with the healthcare system. I am trying to change it from within. Um, and I hopefully can, at least in my little corner of the world. And maybe it'll grow. Experiencing ableism as a professional. Yeah, I've had doctors talk to me or look at me like I wasn't there. And I can honestly say I don't know if it was because I was a nurse or because they saw me as disabled and I'm currently in a wheelchair full time. And, look, I had just last week, I think they were students. I was going into like the supply closet and they came up and they're like, "Oh, do you know where you're going? That's only for staff." I'm like, waving my little waving my little badge, going, "Hi, staff." you know, Frustrating. And then frustration with non-disabled peers. Um, Sometimes it's really hard to explain to people why somebody may be doing what they're doing, or what my life experience is, or what the disability experience is, and that we're not a monolith, that there are all different experiences, and maybe you need to look at this from a different perspective. Next slide, please. Um, Representation appears to be making a difference in the clinic I work at. We're currently doing the research to improve our patients and what our patients and families have told us to other departments. Uh, Told us, yeah, okay, sorry. We're currently doing the research to prove what our patients and families have told us um, to other departments and other healthcare systems. Our work is scalable if changes are made to the education system of clinicians without medical and allied health schools opening their doors to disabled people and hiring disabled staff will be impossible. This is more than just my clinic, and we know it. This is where we need to, set an example and say, this works here. This is why it works for us. And this is what we need to do so it might work for you. And as we get larger and bigger and have it spread so that we have PCPs who are disabled, so that we have oncologists who are disabled, so that we have different docs, different walks of life who either have always been disabled because that gives an interesting perspective, or who become disabled and don't give up their practice and just keep going and growing this so that we have people who are informed, who get it, and maybe can spread the word to the others. Next slide, please. I think that's the end. Thank you for your time, and thank you for caring about our shared community. Does anybody have any questions?
Yeah, Monica, I'm sorry I was late, so I missed part of this. Is this recorded that we can access the recording later?
Yes, it's recorded and it will be available on YouTube on the Access Mob channel. And yeah, you can either raise your hand or you can type in chat. Anybody else have any questions?
This is Elisa, just letting people know that if you have any questions, you can type them in the chat for our media manager, Katie, to read out loud to everyone. You may raise your hand, and if you are on your phone, it is *9 to raise your hand and *6 to unmute yourself. We will be, as I mentioned at the beginning, for anyone who came in late, I'm going to be sending out a survey later tonight for people to fill out about, how much they, what they felt about the lecture. And when I do that, I will send out a link to the video recording on YouTube. So if you missed the beginning or anything like that, you'll be able to watch it.
And Elisa, it's fine if you want to, if people want the slides, they can have them.
Well,
Yeah, that's fine.
if you would like, what I can do is I can just send out the slides when I send out the survey. The survey will be going out to everyone who's signed up on Zoom. So if you're on this call right now, you will be receiving a copy of the survey and the slides and things like that. So I will just attach the slides when I send that email out. It will be either later tonight or tomorrow. John,
Straight on that if there is something that is happening that isn't right or that we need to change, I'm either asking for an accommodation or asking for, we need to do this differently, we need to do this better. One example is that I am responsible for a supply closet, and for whatever reason, people decided to dump sheets and stuff in clean bags, like right in front of the supplies that I need. And so I went to my supervisor, my boss, and asked the doctor, I need to do this, I need to get in there. Can we move it? We have done things to talk to talk to different staff that if patients have said that they are uncomfortable with them, doesn't happen that often, honestly. I can only think of one example. And we have talked to the staff and said we need to change this. So that being said, I work for probably one of the most progressive doctors when it comes to disability. Seriously, he is not disabled himself, but he is very much into making sure that the disability community has what they need and that we don't have ableism. And this is somebody who is, I am blessed with him. And so that, uh, I know I'm saying, oh, I just straightforward address it. Well, that's why it's the culture that we have striven for and we have cultivated, that we have grown there. I hope that answers your question. Um, we also, we don't work, in a bubble. We reach out to other disciplines, to other doctors, and we do take seriously what people say to us about other doctors, and we will not refer to them. If someone says they have this awful, awful, awful experience with this doctor, and specifically, something, the doctor doesn't have a wheelchair scale, or the doctor said something totally ableist, we will address it with a colleague. I can't make colleagues change, some of them. I could try. But we do address it. And then if it continues to be a problem, we're not going to use them. I don't turn around and tell people who, because I can't, if they walk in the door and they say, oh, yeah, my PCP is this person, my first thought is, oh, bad. I don't tell them, dear goodness, but if they make a complaint about them, at least then I can do something about it, or at least try. Okay. Doesn't matter. I don't know who raised their hand first. I can't see it.
Just a question. Good job, Monica. Are there any areas where people with disabilities might not fit in the medical field? I was thinking more specifically about surgery, things like that. Are there areas that they might not fit?
Um, One I could see is the emergency room. Depending on what you're doing, bedside at the emergency room would be really difficult to do. You have to be able to jump up on a stretcher sometimes and pound on somebody's chest. Um, the way that hospitals are set up, they would have to be set up differently too, because like my wheelchair would get in the way. Surgery, not so much. There's actually a neurosurgeon. She's the chief of neurosurgery at Michigan State. She has spina bifida and she uses a power wheelchair, and she works as a neurosurgeon. So if there's a will, there's a way. I am of the opinion that we should explore options, but I can see where the emergency room wouldn't work. Possibly an ICU, not sure.
Thank you. It's interesting about the surgery because now a lot of technology is used. The things
Yeah,
being manipulated by the surgeon as opposed to the surgeon actually doing it himself.
exactly.
So I could see that working also. So thanks for your answer.
Yep. Okay.
Monica, I just want to say first, thank you for your talk. I thought it was fantastic.
Thank you.
And I am a wheelchair user myself. I'm an occupational therapist.
Hmm.
And I was wondering if you could talk about sort of ableism you've experienced when you go for job interviews, because that, at least for me, has been a bit of a barrier, is showing up for the interview as a wheelchair user. And I can speak and self-advocate for myself to my abilities, but sort of how do we move the needle and get employers and healthcare to be accepting of people with disabilities in these fields?
I, yeah, I understand that problem, spot on. I was not a wheelchair user when I was going on job interviews. However, throughout my career, I went from looking, you knew something was not quite right with the way I walked, but I didn't look, they didn't, nobody would think that I had spina bifida, to be honest. To I became an amputee and I had a prosthetic leg. I did go on a job interview where I went for to be a discharge planner in a hospital in Connecticut, and it went. You know how an interview goes well, like it went well. Everything she was talking about me shadowing people, and I was wearing a long skirt, and I moved, and all of a sudden she could see my prosthetic leg. Now I don't can't hide that, like wheelchair can't hide that. Her tone changed just like that. It was bam, oh, do you think you can do this? You have to run from floor to floor. And I'm like, well, your hospital should be accessible. And if I really can't do it, I can ride on a scooter, I would think, because we do have patients in wheelchairs here. Um, And it just, no more shadowing, no more anything. I went to the EEOC, and it was he said, she said. We need to strengthen the laws. That's part of it. We need to strengthen the laws. We need to strengthen a way that we do things. Right now, you have AI that is screening applications, which I think harms disabled people. I think we need to strengthen laws, and we need to do more education in the schools. This was a nurse who wasn't going to hire me. And we need to do education not just in the clinical side, but on the admin side of what the benefits are of having people who with lived experience working in your hospital. Um, I, God, goodness knows that UPMC knows the benefit of trying to use us as advertising. Okay. Not my favorite thing, but it's important. And if it gets more people involved and more people recognizing that disabled people can do these kind of jobs, the best we can. I wish I had a better answer for you. I think a lot of it is advocacy. A lot of it is getting involved with, like Ted Kennedy Jr. does, workplace, getting more people into Fortune 500 companies. Joyce Bender does that work here in Pittsburgh and also on a national level. There's also Josie Badger, who tries to do legislation. We need to change the hearts and minds of society. And I think we can do that by being out there and living our lives and having people see us more and more in more and more spaces. I wish I had a better answer. I honestly wish I could just have a magic wand and just say, poof, I can do this job.
Yeah, no, absolutely. Thank you. I appreciate it.
You're welcome. Okay. Actually, there is a lot of what they're talking about now that they haven't done it yet, but we can push for more disabled people being in medicine and talk to your doctor, your clinician, your nurse, your OT, PT, any speech therapist, anybody who will listen CNA about how you think that there should be more disabled people. Talk about it. And the other thing is that there is a program, and I cannot remember where it was written, but there's such a thing as a disability doula that I think is a cool idea. They have death doulas and they have doulas for birth, and this would be a disability doula. And it is somebody that if you see somebody who's newly disabled or newly wheelchair user, or whatever it is, that there is somebody there to help them, not necessarily a peer navigator, but sort of what a doula does, kind of helping you guide your way or helping you out with different things. I think the difficulty is trying to match disability to disability, and there's a few things involved, but that is difficult. And there is also in Pennsylvania a position called community healthcare worker. They exist, and they are people who are in the community, that they're not doctors or nurses or anybody like that, but they have a certain amount of training, and they're licensed by the state, and they can assist people within their community. And I think that's what we need to look at. We need to look at doing community work and helping each other, because it's becoming obvious that pulling people from outside the community and bringing them in is getting more and more difficult. I mean, specifically direct care workers. So we need to look at our own communities and kind of expand upon that. Who can do what? Okay, my own example is I live with Rick, and Rick is hard of hearing. I have problems with mobility. Um, Rick, I am Rick's ears when he needs me to be, and he is my legs when I need him to be. So kind of pulling together and working together and something along those lines. Agreed? Agreed. Yes. And forgive me, I was thinking more along the lines about mobility disability because that is my disability. But I could see where it really depends on the person. Somebody who is autistic may not do well in the ER because it's so noisy and they wouldn't be able to control the noise. There are agreed. It depends on the disability and it depends on what the situation is. But I think the bigger problem that we have is that by and large, people are looking at people with disabilities and saying, you can't do that at all. Um, Not so much out here, but when I was in Connecticut, do you know where I didn't see disabled people working? In hospitals, in doctors' offices. I didn't see anybody working there. Saw plenty of disabled people, but they were all patients. I think we need to change that dynamic or at least improve the numbers. And just because somebody's disabled doesn't mean that, I don't understand somebody's experience if they're blind. I don't understand somebody's experience if they're hard of hearing. And even mobility experiences, I don't understand everything other than my own. But I think I can foster more empathy and look for more creative solutions and make sure that the person's needs are met the way they would want them to have them met because of my own experience. And I think that's what we need to do is to kind of pull people into different areas and see what would work and what wouldn't.
Okay. Last call. Do we have any more questions, comments? Well, seeing as we have no more questions or comments, I'm going to turn my camera back on.
I'll turn mine off.
So as a reminder, the survey will be going out at the end of this lecture some point later tonight or tomorrow morning. And we will include, I have this all written down, I will include the link to the YouTube video, and I will include a copy of the slides. If you have any questions for Monica, her email again is still m2, STILL, M as for Monica, and the number 2 at upmc.edu. And if you have any questions for us at Access Mob, we are accessmobpittsburgh at gmail.com. Couple announcements for you. Why will this stop? There we go. Our next 2 upcoming lectures that we've got going on Monday, March 24th, we from 6 to 7:30, we will be having a talk from the Commission on Human Relations on who they are, what they do, and how they can help the disability community. That is going to be a hybrid lecture, so it's either online or in person at the Carnegie Library in East Liberty. There is, there's a QR code there to the side of each event that will take you to the web page, or you can go to accessmobpittsburgh.org, and up on top there is a drop down menu for community lecture nights, and you'll be able to you click on the individual pages. Monday, May 19th, from 6 to 7:30. That is going to be our next one after the march. Topic is still TBA. We're working with potential people. Check back soon. Anyone who opted to join our mailing list, you will be getting emails about this. If you're not on our mailing list, things will be popping up on Facebook, on Meetup, and on our website. And those two are the last two lectures that are being funded by the Three Rivers Community Foundation. Thank you again to all of them for their generous grant of being able to help this keep going. But stay tuned because we are working on other funding to get uh, more lectures going and other activities, which you can find out about by joining our mailing list. And finally, this thing. There we go. We rely so much on donations from our supporters to keep us going. If you have any way of helping us out, we greatly appreciate it. There's QR codes here to our PayPal, our Cash App, and our Venmo. Please be sure if you donate through either of those, there's going to be a section where you can write a comment. Please put AMP for Access Mob Pittsburgh in that section so that our fiscal sponsor, Disability Pride Pennsylvania, knows to send the money directly to us. If you don't want to or can't do it off the QR code on the page that's up now, if you go to accessmobpittsburgh.org/donate, that gets you a direct page. And yeah, thank you again so much to Monica for speaking with us tonight. Thank you everyone who came. And please stay warm out there, stay safe, and we hope to see you again at our next lecture. Have a good night. And then